Welcome to the MRC-pology channel for a quick review, understanding, and revision of the topic. Imagine an older patient comes to clinic with rapidly worsening stiffness, slow movements, dizziness on standing, urinary urgency, and falls. At first glance, this may look like Parkinson's disease, but the speed of progression, the early autonomic symptoms, and the poor response to levodopa should make you think of multiple system atrophy. Multiple system atrophy, or MSA, is an atypical Parkinsonian syndrome. That means it can look like Parkinson's disease, but it behaves differently. It progresses faster, it affects more systems, and it usually responds poorly to levodopa. The basic problem in MSA is abnormal α-synuclein accumulation. In Parkinson's disease, α-synuclein mainly affects neurons. In MSA, the key point is that α-synuclein accumulates mainly in oligodendroglia. Oligodendroglia are the support cells that help maintain myelin and support nerve function in the central nervous system. So, misfolded alpha-synuclein leads to glial cytoplasmic inclusions, then oligodendrocyte dysfunction, then neurodegeneration. The result is combined motor failure and autonomic failure. To make MSA easier, think of three pathways being damaged. First, the striatonigral pathway. This gives the Parkinsonian form called MSA-P. Patients develop bradykinesia, rigidity, postural instability, and falls. Tremor can occur, but it is usually not the classic resting tremor seen in idiopathic Parkinson's disease. Second, the olivopontocerebellar pathway. This gives the cerebellar form called MSA-C. Patients develop gait ataxia, limb ataxia, slurred speech, nystagmus, and imbalance. In simple terms, the cerebellar system controls coordination, so when it degenerates, the patient becomes unsteady, clumsy, and dysarthric. Third, the central autonomic pathways. This is one of the most important exam clues. Damage here causes neurogenic orthostatic hypotension, urinary urgency, urinary retention, erectile dysfunction, and constipation. Neurogenic orthostatic hypotension means the blood pressure falls on standing because the autonomic nervous system cannot constrict the blood vessels properly. So the patient feels dizzy, faints, or has recurrent falls. Now compare this with Parkinson's disease. Parkinson's disease is usually slower. It often has a better levodopa response. Autonomic symptoms may occur, but severe early autonomic failure is much more suspicious for MSA. In MSA, levodopa often works poorly because the postsynaptic striatal circuits are also damaged. In Parkinson's disease, the main problem is loss of dopamine-producing neurons, so giving dopamine replacement can help more. In MSA, the receiving circuits are damaged too, so the response is limited. Clinically, the key clue is early autonomic dysfunction plus either Parkinsonism or cerebellar ataxia. Postural dizziness or syncope happens because the autonomic nervous system fails to maintain blood pressure when the patient stands. Urinary urgency, incontinence, or retention happens because bladder control is impaired, especially detrusor and sphincter coordination. Erectile dysfunction and constipation are also autonomic features. The motor features can be mainly Parkinsonian, mainly cerebellar, or mixed. Later in the disease, overlap is common. MSA-P looks more like Parkinson's disease with bradykinesia and rigidity. MSA-C looks more like an ataxic disorder with unsteady gait, limb incoordination, dysarthria, and nystagmus. MRC-P trap. Do not call every Parkinsonian syndrome Parkinson's disease. Rapid progression, early falls, severe dysautonomia, inspiratory stridor, dysphagia, dysarthria, pyramidal signs, and poor levodopa response are red flags against idiopathic Parkinson's disease. Inspiratory stridor is particularly important. It suggests laryngeal involvement and sleep-disordered breathing, and it can be dangerous. REM sleep behavior disorder is also common. This means the patient acts out dreams during sleep because normal muscle paralysis during REM sleep is lost. Now let us separate MSA from some close differentials. Parkinson's disease usually has asymmetric onset, resting tremor, slower progression, and a good levodopa response. MSA progresses faster, causes early autonomic failure, and responds poorly to levodopa. Progressive supranuclear palsy, or PSP, also causes atypical Parkinsonism and early falls, but the classic clue is vertical gaze palsy, especially difficulty looking down. PSP is more about eye movement problems and axial rigidity, while MSA is more about autonomic failure and cerebellar or Parkinsonian features. Dementia with Lewy bodies gives Parkinsonism too, but the main clues are early dementia, visual hallucinations, cognitive fluctuation, and REM sleep behavior disorder. In MSA, dementia is not usually the leading early feature. Cerebellar ataxias can mimic MSA-C, but they usually lack severe early autonomic failure. So in an adult with progressive ataxia, urinary dysfunction, erectile dysfunction, orthostatic hypotension, and poor coordination, MSA-C becomes much more likely. The diagnosis is mainly clinical. Think of an adult-onset progressive syndrome with autonomic failure plus either Parkinsonism or cerebellar ataxia. Definite diagnosis is pathological, meaning it is confirmed by tissue findings, usually after death. In practice, we use clinical categories such as clinically established MSA and clinically probable MSA. MRI can support the diagnosis. You may see putaminal atrophy or hypointensity in MSA-P. You may see pontocerebellar atrophy in MSA-C. The classic imaging clue is the hot cross bun sign in the pons, especially in MSA-C. But remember, imaging supports the diagnosis. It does not replace clinical reasoning. Always exclude mimics. Parkinson disease, PSP, dementia with Lewy bodies, hereditary or sporadic ataxias, cervical myelopathy, paraneoplastic or autoimmune disease, vitamin B12 deficiency, and copper deficiency can all confuse the picture. This is especially important when the presentation is atypical, younger than expected, or rapidly progressive. Treatment is symptomatic because there is no disease-modifying therapy. The aim is to improve quality of life, reduce falls, manage autonomic symptoms, support swallowing and breathing, and plan ahead. A levodopa trial is reasonable, especially in MSA-P, but the response is often limited. This is useful clinically and diagnostically. A poor response supports atypical Parkinsonism, but it does not by itself prove MSA. Orthostatic hypotension should be treated step by step. Start with fluids, salt, compression garments, and sleeping with the head of the bed elevated. These measures help maintain circulating volume and reduce postural blood pressure drops. If symptoms persist, drugs such as midodrine or fludrocortisone may be used, but you must watch for supine hypertension. Supine hypertension means the blood pressure becomes too high when the patient is lying down. Bladder symptoms need careful assessment. Do not simply give antimuscarinic treatment to every patient with urinary urgency. First, check the post-void residual. If the patient has urgency without retention, an antimuscarinic or a beta-3 agonist may help. But if there is significant retention, these drugs can make it worse, and intermittent catheterization may be needed. Management is multidisciplinary. Physiotherapy helps mobility, balance, and falls prevention. Speech and language therapy helps dysarthria and swallowing. Nutrition support is important if dysphagia develops. Constipation and erectile dysfunction should be treated actively. Stridor needs respiratory review because it can indicate upper airway involvement. Advanced care planning is important because MSA progresses faster than Parkinson's disease. Prognosis is typically worse than idiopathic Parkinson's disease. Many patients need a wheelchair within a few years, and survival is often around 6 to 10 years from onset. This is why early recognition matters, not because we can cure it, but because we can anticipate complications, reduce harm, and support the patient properly. If you remember one thing, remember this. MSA is Parkinsonism or cerebellar ataxia plus early autonomic failure, with rapid progression and poor levodopa response. Quick recall. A patient with bradykinesia, rigidity, recurrent syncope on standing, urinary retention, and poor levodopa response is labeled as having Parkinson's disease. What features should make you reconsider the diagnosis, and what condition should you suspect? The answer is early severe autonomic failure, especially orthostatic hypotension and urinary retention, which should make you suspect multiple system atrophy. A patient has progressive gait ataxia, dysarthria, nystagmus, erectile dysfunction, and an MRI showing a hot cross bun sign in the pons. Which subtype of MSA is most likely and which pathway is mainly involved? The answer is MSA-C due to olivopontocerebellar degeneration affecting cerebellar coordination pathways. Do subscribe to the channel for further videos.